Hello, everyone, and welcome to our session, Hot Topic, Coronavirus and Kidney Patients Update, a CDC expert session. I am Dr. Janice Lee, a proud member of the AAKP National Board of Directors, also a member of the AAKP Executive Committee. I am also a professor of medicine and clinical director of nephrology at Emory University and am the chief medical director of Dialysis. I am involved with the AAKP because it is truly a patient-led organization, and its main commitment is to patient wellness and advocacy. Those are top priorities, which align with my priorities as a clinician. My involvement with the AAKP has been one of the most rewarding aspects of my entire medical career. I represent AAKP on a number of initiatives, including the PCORI-funded AAKP Engagement Award. I serve as an AAKP representative on the Patient and Provider Advocates for Telehealth and am an advisory board member to the NIH Apollo program involved in increasing kidney transplant donation. I am pleased to introduce Dr. Shannon Novosad, who is Medical Officer of the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. AAKP has a strong, long history of promoting patient safety and infection control efforts through its Patient Safety Award program and shares a close collaboration with the Centers for Disease Control and Prevention. In fact, AAKP awarded its prestigious National Public Service Awards to Dr. Preeti Patel, former dialysis activity leader within the Division of Healthcare Quality Promotion of the CDC, and was a founding partner of the CDC Making Dialysis Safer Coalition in 2016. The CDC and AAKP co-branded a conversation starter to prevent infections in dialysis patients, which provides guidance for patients and their family members to initiate a discussion with dialysis facility staff about important steps the facility can take to prevent infections. The AAKP is also pleased to have its Chair of Policy and Global Affairs, Paul Conway, serve as the AAKP liaison to the CDC's Health Infection Control Practices Advisory Committee. In the midst of the COVID-19 pandemic, AAKP has been proud to work alongside our allies across the kidney community in a collaborative effort to gain greater protections for all kidney patients, especially those most at risk, and their families. And thanks our friends at the CDC and all U.S. civil servants who have honored their oath to serve our nation, and for their courage and dedication to high ideals of public service during this national health and workforce crisis. Many of you viewing this session may recognize Dr. Novosad, as she's been a constant presence since 2020, providing important and timely health updates to AAKP members on how to remain as safe as possible during the coronavirus pandemic. Without further ado, I'd like to welcome our guest speaker, Dr. Novosad.
Hi, thanks so much for the opportunity to speak with you all today. I'm Shannon Novosad from the Centers for Disease Control and Prevention, and I'm going to talk today about COVID-19 vaccines. I'm going to hit on a number of different topics as they relate to vaccines, and when there is information specific to kidney patients, I will make sure to point that out. So a few disclaimers. One, I won't cover any single topic in a lot of detail. What I really want you to take away is a high-level overview of where we are with vaccines and the systems in place to help CDC and other groups make recommendations on vaccine. And second, it is possible that the information shared during this session will change or be updated in the coming weeks as we learn more about COVID-19. In the 18 months since COVID-19 infections were first identified, multiple COVID-19 vaccines have been developed and put through clinical trials with the support of the US government. Vaccination is a critical tool in bringing this unprecedented pandemic to an end. This slide shows a snapshot of what we have accomplished to date. As of September 7th, the U.S. has administered more than 375 million doses, and 53% of the population is fully vaccinated. 63% have received at least one dose. Of those 12 years and older, the percentage of fully vaccinated is higher at 63%. On the map, the darker shades of blue show higher vaccination rates. This effort has been possible by collective and coordinated action from state and local jurisdictions, federal agencies, and private partners. CDC continues to work with jurisdictions to understand roadblocks and figure out how to overcome challenges in distribution and administration to ensure that we are getting vaccines into arms as quickly and safely as possible. There are 3 vaccines widely available to use. The Pfizer vaccine was approved by FDA on August 23rd, and 2 other vaccines have received emergency use authorizations from the FDA, one produced by Moderna and one by Johnson & Johnson or Janssen. The Pfizer vaccine is FDA approved for individuals 16 years of age and older, and it continues to be available under emergency use authorization for individuals 12 through 15 years of age, and for the administration of a 3rd dose in certain immunocompromised individuals, for example, organ transplant recipients. You'll likely recall this was a relatively recent recommendation. The Pfizer vaccine is an mRNA vaccine that is given in 2 doses at least 21 days apart. The Moderna vaccine is authorized for persons aged 18 years and older. It is also an mRNA vaccine given in 2 doses at least 28 days apart. The EUA also allows for administration of a 3rd dose in immunocompromised individuals. And finally, the J&J vaccine is authorized for persons aged 18 years and older, and it's a single-dose viral vector vaccine. The 3 vaccines were tested in diverse adult populations, including minorities and older adults. All the available vaccines have been proven effective at preventing serious illness, hospitalization, and death from COVID-19 disease. It's currently unknown how long the protection from receiving a COVID-19 vaccine might last, and if some people may not develop enough protection from the vaccine to start with. But we have learned and are learning more about this every day, which has led to the recently updated recommendations for an additional dose in certain immunocompromised individuals, and in the coming weeks, recommendations for when and in who boosters may be indicated are likely forthcoming. An important point to keep in mind, we often use the terms additional doses and boosters interchangeably, but they aren't the same thing. Additional doses are designed for people that didn't have an adequate immune response to start with, while booster doses are meant to boost immunity that has started to decrease. So that means recommendations may come at different times for different groups of people based on these factors. So sometimes you'll hear a new recommendation that calls for an additional dose, while other times you may hear a recommendation that calls for a booster. And the reason behind this is, just these different indications for both of these. We realize that you or your family and friends may have concerns about the safety of these COVID-19 vaccines because they use new technology. However, they were based on years of research. So while the mRNA technology is new, it's not unknown. It's been studied for decades in vaccine trials for influenza, Zika, and rabies. And beyond vaccines, cancer research has also used mRNA to trigger the immune system to target specific cancer cells. Scientists began creating viral vectors in the 1970s. Viral vectors have also been studied for gene therapy to treat cancer and for molecular biology research. For decades, hundreds of scientific studies of viral vector vaccines have been done and published around the world. Some vaccines recently used for Ebola outbreaks have used viral vector technology, and a number of studies have focused on viral vector vaccines against other infectious diseases such as Zika, flu, and HIV. Another critical piece has been the investment in manufacturing even before COVID-19 vaccines were proven effective. The US government and vaccine manufacturers invested millions of dollars to scale up vaccine production while clinical trials were in progress, greatly reducing the amount of time between vaccine authorization and vaccine implementation. Because of the great financial risk, the investment in manufacturing normally doesn't happen until later in the development process. Also notably, mRNA vaccines are faster and cheaper to produce because they use ready-made materials. FDA and CDC have been and are working quickly to prioritize review and approval of COVID-19 vaccines during the pandemic. Millions of people in the US have received COVID-19 vaccines under the most intense safety monitoring in US history. All COVID-19 vaccines in development have been and are being carefully evaluated in clinical trials and will only be authorized or approved if the benefits outweigh potential risks. The FDA and CDC will continue to closely monitor the safety of these vaccines. And getting vaccinated can help protect those around you, especially those at increased risk for severe illness. And while it may sound scary to hear about side effects or adverse events related to the vaccines, us finding out about them is an indication that these surveillance systems, which we'll talk about in the next several slides, that monitor the safety of COVID-19 vaccines are working. COVID-19 vaccines are being held to the same safety standards as other routine vaccines. Several expert and independent groups evaluate the safety of vaccines being given to people in the United States. Before any vaccines receive authorization or approval, the FDA carefully reviews all the safety data from clinical trials. And the Advisory Committee on Immunization Practices, or ACIP, which is an independent body of experts that we'll discuss in more detail later, reviews all safety data before recommending use. FDA and ACIP have qualified scientific and clinical experts with minimal conflicts of interest reviewing all of the data. After any vaccines are authorized and in use, both FDA and CDC continue to monitor their safety. Existing systems can rapidly detect possible vaccine safety problems. These systems have been scaled up for the COVID-19 vaccine to fully meet the needs of the nation. Additional systems and data sources are also being used to further enhance safety monitoring capabilities. This slide shows a graphic of the various systems that are being used to monitor COVID vaccine safety and highlights the robust nature and diversity of these systems. I will highlight a few of these and the ways in which they collect data. All data collection systems have some limitations, so it's important that we have systems that collect data in different ways to get the best information possible regarding vaccine safety. These systems enable both active surveillance, which involves reaching out directly to patients and or providers to see if they've had any adverse events related to the vaccine. For example, VSafe, shown here in the middle of the slide in yellow, and passive surveillance, which allows patients or providers to report events as they occur into an existing system, for example, VAERS, which is right underneath it in the middle in green. We'll talk more about these both in the next few slides. Providers can also reach out to the Clinical Immunization Safety Project, or CISA, and request individual case consults on vaccine safety events. There are also large linked databases that collect information from across the country and can perform more rigorous evaluations of vaccine safety. One example of this is the Vaccine Safety Data Link, or VSD. It's a collaborative project between CDC and 9 healthcare organizations, and it was started in 1990 and continues today in order to monitor the safety of vaccines and conduct studies about rare and serious adverse events following immunization. It uses electronic health data from each of the 9 participating sites and conducts vaccine safety studies based on questions or concerns raised from the medical literature and reports to the systems that I mentioned earlier, such as VSafe, VAERS, and CISA. So as I mentioned, I'm going to highlight 2 of these systems in a little bit more detail. The first is VSafe. This is a smartphone-based tool that uses text messaging and web surveys to provide personalized health check-ins after someone receives a COVID-19 vaccine. Through VSafe, participants can quickly tell CDC if they've had any side effects after getting the vaccine. And depending on the answers, someone from CDC may call to check on them and get more information. There's also a mechanism built in to remind people to get their second COVID-19 vaccine doses if they're needed. Everyone who has received a vaccine is encouraged to participate. All that's needed to register is a smartphone. And a person can either talk to their vaccine provider about enrolling when they get the vaccine, or they can actually just go directly to CDC's website for more information. This slide here outlines the information flow for this VSafe text messaging process, which basically involves number one, which is someone enrolling in the system. And after that, they're going to get text message check-ins from CDC, which happen daily for the first week, and then weekly through 6 weeks, and then at 3, 6, and 12 months. And they'll be asked questions about if they're having any events or if anything's occurring. If they do report that a clinically important, event has occurred, they will likely get a call from the call center, and will collect more information on this event, and if appropriate, file a VAERS report, which we'll get into in the next slide. There's also a mechanism built in to enroll people in a specific registry looking at adverse events occurring in pregnancy through the VSafe mechanism. And so again, this is what we call active surveillance. So someone, i.e. this text messaging system, and then maybe someone from CDC calling, is actively reaching out to someone to see if they've had any side effects or adverse events after the vaccine. And then on to VAERS, which I know I've mentioned several times now. So it's the Vaccine Adverse Event Reporting System. It's a national vaccine safety surveillance program that's run by CDC and FDA. It really serves as an early warning system to detect possible safety issues with vaccines by collecting information about adverse events or side effects that occur after vaccination. Notably, this system was in place prior to COVID vaccine availability and has been used to monitor other vaccines, and it's currently also being used to monitor other vaccines. Traditionally, the reports are placed via an online reporting platform. This slide shows some of the strengths and limitation of the VAERS system. Some of the strengths is that we're able to collect data across the country, so national data. It can actually really rapidly detect safety signals as soon as the reports are generated in the system. People can be pinged to review them. It can detect rare adverse events, and the data is available to the public. Limitations, there is a reporting bias. So again, this is passive surveillance. So we're relying on people or providers who had these events or noticed these events happening in their patient to submit these reports. There could be inconsistent data quality or incompleteness of information because not everyone who makes a report completes all the fields in the online system. There's not an unvaccinated comparison group, so we're not able to determine if the event in question is also happening at the same level in people who have not been vaccinated. And it's not designed to assess causality. So we're not able to take the information from VAERS and say that it was definitely caused by the vaccine. So they accept all reports from everyone regarding the plausibility of the vaccine causing the event or the clinical seriousness of the event. And its value really lies in it being a hypothesis generating system, which means it identifies potential vaccine safety concerns that can be studied in more robust data systems. So one example of the data being reported to VAERS being used to inform our current knowledge of vaccine safety is further evaluation of myocarditis or inflammation of the heart events that have occurred in patients who've received the mRNA COVID-19 vaccines. So CDC is actively investigating reports of people who have developed myocarditis after receiving an mRNA COVID vaccine, and they're using these reports in VAERS to actually reach out to people and get more information on the event that occurred and any possible long-term effects. So to summarize, for COVID-19 vaccines, CDC and federal partners are using a toolbox of existing and new monitoring systems for COVID-19 vaccine safety. CDC relies on existing systems that monitor the safety of vaccines every day, such as VAERS, the Vaccine Safety Data Link, and CISA project. But CDC has also developed a new voluntary smartphone-based tool called VSafe that uses text messaging and web surveys to provide personalized health check-ins after patients receive a COVID-19 vaccine. We're committed to continuing to communicate clearly on the vaccine safety process and the systems that are used, and will provide safety data and monitoring results to the public in a timely and transparent manner. Strategic partnerships have contributed to our ability to increase access across the country and more equitably to the COVID-19 vaccine. Strategic partnerships have also been critical to the success of getting the vaccine in arms. Without the partnerships shown on this slide, we would not be anywhere close to where we are with vaccine administration today. These include partnerships with long-term care facilities, retail pharmacy programs, federally qualified health centers, state and federal infrastructure such as primary care providers, and the renal dialysis program. I want to specifically talk about the renal dialysis program. It's not surprising to this group that providing access to vaccine on-site at dialysis facilities is critical for patients on dialysis. Two large dialysis partner organizations, DaVita and Fresenius, have enrolled as COVID-19 vaccination providers to increase access to COVID-19 vaccines across dialysis clinics nationwide. These two providers operate approximately 83% of dialysis clinics in the US, and they have extensive reach across the country. And we knew they had the operational, logistical, IT infrastructure, and cold chain and pharmaceutical delivery capacity to serve as capable vaccination providers. However, this partnership also supports the delivery of vaccines to other smaller clinics not owned by DaVita or Fresenius. DaVita and Fresenius are registered under a network administrator agreement and are supporting the delivery of vaccine doses to smaller dialysis organizations and independent providers that have joined the networks. In consultation with CDC and other groups such as the American Society of Nephrology, dialysis partners were able to help develop this strategy to equitably distribute vaccine across dialysis clinics. CDC is monitoring the distribution of vaccine to help ensure fair access. This program launched in March and is ongoing and remains in place for the administration of additional doses and boosters when the time comes for patients and healthcare personnel. Now let's shift to talking more specifically about communications and building vaccine confidence. The communication activities and outreach efforts we undertake related to the COVID-19 vaccine really depend on vaccine confidence. We define vaccine confidence as the trust that parents, patients, or providers have in the safety and efficacy of recommended vaccines, providers who administer vaccines, and processes and policies that lead to vaccine development, licensure, manufacturing, and recommendations for use. This foundation of trust is critical. Now, where you also play a role in trust in vaccines and the vaccine program, you are part of the system that people interact with to learn more about when and where they can get vaccinated. This is the CDC Vaccinate with Confidence strategy for COVID-19, and many of these approaches may serve you well too in building vaccine confidence in your respective organizations or amongst your families and friends. The first objective is to share clear, complete, and accurate messages about COVID-19 vaccines and take visible actions to build trust in the vaccine, the vaccinator, and the system in coordination with federal, state, and local agencies and partners. This includes communicating transparently about the process for authorizing, approving, making recommendations for, monitoring the safety of, distributing, and administering COVID-19 vaccines, providing regular updates on benefits, safety, side effects, and effectiveness, and importantly, to clearly communicate what is not known. Proactively address and mitigate the spread and harm of misinformation via social media platforms, partners, and trusted messengers. The second objective is to promote confidence among healthcare personnel in their decision to get vaccinated and to recommend vaccination to their patients. While I know the primary audience today may be patients, certainly there are some healthcare personnel on, so I think it's important that you hear, and some of you patients may also be healthcare personnel. So this means engaging national professional associations, health systems, and healthcare personnel often and early to ensure a clear understanding of the vaccine development and approval process, new vaccine technologies, and the benefits of vaccination. Ensuring healthcare systems and medical practices are equipped to create a culture that builds confidence in COVID-19 vaccination, and strengthening the capacity of healthcare professionals to have empathetic vaccine conversations, address myths and common questions, provide tailored vaccine information to patients, and use motivational interviewing techniques when needed. And the third objective is to engage communities in a sustainable, equitable, and inclusive way, using two-way communication to listen, build trust, and increase collaboration. This means empowering vaccine recipients to share their personal stories and reasons for vaccination within their circles of influence, working with health departments and national partners to engage communities around vaccine confidence and service delivery strategies, including adaptation of vaccination sites to meet community needs, and collaborating with trusted messengers, such as faith-based and community leaders, to tailor and share culturally relevant messages and materials with diverse communities. Building confidence and generating demand go hand in hand. So again, vaccine confidence is building trust in the vaccine, the vaccinator, and the system, while demand generation involves mobilizing individuals and communities to seek, support, and advocate for vaccines. Some keys to building demand for vaccines include making vaccines accessible, beneficial, convenient, desirable, normative, and necessary. And while we at CDC often talk directly to healthcare personnel, these same messages do apply broadly. Think about your friends and family, your church, your workplace, your dialysis facility. This list can go on and on. You may be one of the most trusted sources of information, but if you aren't, you probably know who is. Find the most trusted source of information and work through those who are to help increase vaccination among your community and your friends and family. Vaccine hesitancy, especially when rooted in lack of trust rather than lack of information, is best addressed through trusted messengers and trusted spaces. Encourage the two-way dialogue and allow space for people to ask questions. All right, so switching gears again, I wanted to touch briefly on ACIP so you can better understand how the recommendations for who should be vaccinated and when vaccines should be administered actually get made. So as I've mentioned, ACIP stands for the Advisory Committee on Immunization Practices, and it was established in 1964 by the Surgeon General of the U.S. Public Health Service and was designated a Federal Advisory Committee in 1972. The ACIP develops recommendations on how to use vaccines to control disease in the United States. The committee deliberates on the use of vaccines to control disease in the U.S. and includes considerations of many different subjects, including the following: the disease epidemiology, so who the disease infecting, when and where, and the burden of disease, vaccine efficacy and effectiveness, vaccine safety, the quality of evidence being reviewed, economic analyses, and implementation issues. CDC is a secretariat for ACIP, but ACIP is independent of CDC. Voting ACIP members are not CDC employees. They are an independent group of medical and public health experts. They come from a variety of backgrounds and represent various organizations with expertise in immunizations. Notably, ACIP only makes recommendations on the use of vaccines after there is regulatory action by FDA allowing for such use. For example, ACIP didn't recommend vaccination for those 12 to 15 years old until FDA expanded the Pfizer EUA to include this age group. Manufacturers and drug companies must submit data to FDA before FDA can take regulatory action. So as you can see, these steps happen in a certain order. The FDA approves licenses for vaccines, but ACIP makes recommendations for the use of those FDA licensed vaccines. The recommendations come after thoroughly evaluating all available data, and the ACIP recommendations are what providers use to decide which vaccines should be administered and to which individuals. The committee's recommendations are forwarded to CDC's Director for approval. Once they've been reviewed and approved, they are published in CDC's Morbidity and Mortality Weekly Report, also known as the MMWR. This publication represents the final and official CDC recommendations for immunization of the U.S. population. And under provisions of the Affordable Care Act, immunization recommendations of the committee that have been adopted by the Director of the CDC must be covered by applicable health plans. Here, I just wanted to point you towards the ACIP website. Here you can find information on upcoming meetings, as well as slides and minutes from recent meetings. These meetings are open to the public, and there are even opportunities for members of the general public to submit comments either in writing prior to the meeting or to apply to speak verbally during the meeting. The next meeting hasn't been scheduled yet, will likely be later in September. The format of the meetings is usually as follows. It starts with a presentation of data, such as that pictured on this slide. Then the committee deliberates and then votes. Sometimes data that is early or preliminary will also be discussed at these meetings in anticipation of future FDA regulatory action and an opportunity to an ACIP vote at a future meeting. For example, at a recent ACIP meeting on August 13th, the data surrounding the need for additional doses in some groups was discussed. This slide was one of the slides presented at that meeting and is available along with others to review on the ACIP website. This shows the percent antibody response of various groups, including cancer, hemodialysis, organ transplant, and immunosuppressive therapies. As you can see, the antibody response for certain groups had a wide range and was less robust than what was seen in the general population. There was subsequently a vote after the presentation of this data, leading to the following recommendation, which most of you have probably heard and many of you may qualify for. People with moderately to severely compromised immune systems are especially vulnerable to COVID-19 and may not build the same level of immunity to the 2-dose vaccine series compared to people who are not immunocompromised. This additional dose is intended to improve immunocompromised people's response to their initial vaccine series. CDC recommends that people with moderately to severely compromised immune systems receive an additional dose of an mRNA COVID-19 vaccine at least 28 days after a second dose. If anyone has questions about whether they are moderately to severely immunocompromised and should receive this additional dose, they should talk with their healthcare provider. Although CDC does not recommend additional doses or booster shots for any other population at this time, their HHS has announced a plan to begin offering COVID-19 vaccine booster shots this fall. Before this decision can be implemented, as per the processes previously described, the FDA will need to take regulatory action, at which ACIP will review the data before making a recommendation. We all know no vaccine is perfect or works 100% of the time. A COVID-19 vaccine breakthrough is defined as a SARS CoV2 infection in a person who is fully vaccinated. With over 100 million people vaccinated, we expect thousands of breakthrough cases to occur. Evidence suggests that vaccinated people with breakthrough infections will have less severe illness than unvaccinated people who get COVID-19. However, despite this, some fully vaccinated people who get COVID-19 will have a severe or fatal infection. So we created a passive surveillance system that aims to capture all breakthrough cases that occur throughout the country. We are using this system to monitor for trends in COVID-19 vaccine breakthrough infections and collecting case demographics, which vaccine product was received, and SARS CoV2 viral lineages, are also known as variants. We use the surveillance data to help identify trends that require further investigation or possible adjustments in vaccine recommendations. We know these data represent an undercount. Many infected, vaccinated people will not get tested despite mild symptoms. Data depend on voluntary reporting from state health departments and other groups. The data may not be complete because of lack of reporting. In addition, health departments may not be able to identify all breakthrough cases because of an inability to link case databases with vaccine databases. And finally, determining SARS CoV2 causality for symptoms, hospitalization, and deaths is often difficult. So sometimes it's hard for us to tell exactly how severe these cases are and whether there's another medical illness going on that's actually causing some of the severity. CDC and local laboratories across the country are performing viral sequencing. We're monitoring what viral variants cause vaccine breakthroughs in order to detect if any variants are more likely to cause breakthrough infections. If vaccines are working equally for all viral strains, the proportion of breakthrough cases due to SARS-CoV-2 variants should match the proportion of all cases that are due to variant viruses. No unexpected patterns have been identified in the case demographics or vaccine characteristics among people with reported vaccine breakthrough infections. COVID-19 vaccines are effective, and CDC recommends that everyone 12 years in age and older get a COVID-19 vaccine as soon as they can. For those who are fully vaccinated and get infected, there is a risk of transmission to others. So that's why if you're vaccinated or unvaccinated and live in an area with substantial or high transmission of COVID-19, you'll be better protected if you wear a mask when you are in indoor public places, even if you're fully vaccinated. And then to describe our next actions a bit, on May 1st, CDC transitioned to asking states to report only those vaccine breakthrough cases that are hospitalized or fatal, because these are the cases of greatest public health concern. By focusing on these cases, we are improving our data quality and decreasing the burden on states. Ultimately, CDC will use the National Notifiable Diseases Surveillance System to identify vaccine breakthrough cases. As more states are able to use this already existing system, we'll be able to gather more information on these breakthrough cases. So how do SARS-CoV-2 variants occur? Viruses are constantly changing, and this includes SARS-CoV-2. These changes in the genetic code of a virus are called mutations and naturally occur over time when an animal or person is infected. These mutations can lead to the emergence of new variants that may have different characteristics. So while a certain amount of genetic variation is expected, it's important to monitor circulating viruses for key mutations that happen in important regions of the genome. Many mutations do not affect the virus's ability to spread or cause disease because they do not alter the major proteins involved in infection. However, variants with mutations that enhance the virus's ability to spread or cause disease are able to outcompete other variants. This slide and the following slides show some of the data available on the CDC website regarding currently circulating variants. This data is updated weekly and comes from CDC's National SARS CoV2 Genomic Surveillance Program, which aims to identify variants circulating in the US and calculates the proportion of variants causing infections nationally and by certain regions. This data helps fuel efforts to determine if the vaccines currently authorized for use in the US will work against emerging variants, and also to determine whether the current COVID-19 tests and treatments are currently working. So you can see here on the slide, the different colors in the bar graph represent the different variants and kind of their proportions as they've changed over 2-week periods. And it goes from May 13th to September 4th. You can really see the obvious change here is the increase in Delta, which is kind of the yellow-orange color, and increases to pretty much the whole bar graph by the end of tracking on 9/4. And then the bullets in the side just pull some of those numbers out for you to see. But basically, since the beginning of July to September 4th, Delta has increased from 68.7 to 98.9% of circulating variants, while Alpha has decreased from about 16% down to 0.1%. Gamma is also listed because initially when we were doing this, I think it was number 3, but again, it's pretty much down to 0. And this is just what the data looks like by region. So if you're ever interested in seeing, what's circulating in your area of the country, again, you can go to this website and pull up the specific region that you look in. But really, currently it's just showing the same thing we were seeing on the prior slide, that Delta is greater than 98% in all regions. And I also wanted to point you towards this website. It's basically called the When You've Been Fully Vaccinated website. It's updated frequently as new information becomes available. And I've already, I think, mentioned a few of the points that have been updated previously. But for example, as we learn more about the Delta variant, and that while rare, it's possible for fully vaccinated people who are infected to spread the virus to others, these recommendations were updated. And probably the one that everyone remembers the most is where a new recommendation came out about, wearing a mask indoors, even if you're vaccinated in areas with substantial or high transmission. I won't go through all of the details on this website, but I just wanted you to know it's there and that it's updated frequently as new information comes out. So it's a good one to kind of like bookmark and keep an eye on periodically. So hitting some of the high points we've covered, COVID-19 vaccination can protect you, your family, your friends, and your community. Getting a vaccine and following CDC recommendations is the best way to protect yourself and offer others the best protection. Participating in VSafe can help CDC monitor for any health effects after vaccination. It's important to share your experience with your coworkers, friends, and family, and visibly show that you received a COVID vaccine by wearing a sticker or button. Just remember, you have a role in increasing vaccine confidence. Sharing your experiences may influence those you care about. So we've come a long way and have great momentum, but we still have a lot of work to do. Looking ahead, our COVID-19 vaccine implementation efforts are focused on continued surveillance of variant viruses, continued vaccine effectiveness studies, expanding vaccine-eligible populations, combating vaccine hesitancy, and continuing to focus on vaccine equity. So the last few slides are just pointing you towards some other parts of the website where you can get some more information. This here is the COVID one, kind of like I don't know if it's a landing page or a home page for COVID-19 vaccine. It contains several different areas that will point you towards some of the information we've already covered, but includes a Your Vaccination button to include information about how to find a vaccine, preparing to get the vaccine, and what to expect after you've been vaccinated. When Fully Vaccinated button provides information on how you continue to protect yourself and others after you've been fully vaccinated. And for healthcare workers, provides clinical resources for each of the vaccines, as well as resources for healthcare workers regarding the vaccine. Also on this webpage is a link to Vaccine Finder, which helps people find providers who offer the different vaccines. The CDC COVID data tracker is also publicly available on the CDC website. It's updated pretty much daily and shows the status of the U.S. vaccine implementation effort, among other things, down to the county level within a state. It also includes demographic information, and it was really designed to ensure transparency and accountability. So if you haven't checked it out, it's definitely changed over the months, and there's a lot more data on there than there used to be. So I encourage you to take a look at it. And one of the newer things, the Dialysis COVID-19 vaccination data dashboard was recently added to the CDC website. This page displays data at the national and state level on COVID-19 vaccination coverage among patients and staff of dialysis facilities. These summaries represent data that dialysis facilities report to CDC using a weekly vaccination form. And this data is updated weekly, usually on Thursdays. And then finally, again, probably the one I wanted to point out most on this slide is the bottom. There's a lot of different toolkits available for communication. So again, if any of these apply to you and your role in a particular organization, I encourage you to check them out, and hopefully they have some good tips and techniques that you will be able to utilize. And thanks so much for the opportunity to speak with you all today. I really enjoyed sharing this information about the COVID-19 vaccine. And I really just want to reiterate, as I said at the beginning, things are changing rapidly. So some of the stuff I said may even be old by the time that you're hearing this presentation. But I hope that the resources and the websites provided are a way to help keep you updated. And we're here to support you and AAKP, so feel free to reach out to us with any questions. Thank you.
Thank you, Dr. Novosad, for your outstanding and timely presentation. We appreciate your continued involvement in AAKP programs to share your time and expertise.